question. The first question really is there a prescription drug problem? The answer is yes. Interestingly, though, 10 years ago, maybe 5 years ago, the prescription problem was excessive and liberal use of opioids in the management of pain. Efficacy was oversold and risk was minimized, and we now know that that's not the case. The problem now today in terms of prescription drug problem in America is the legitimate availability of those drugs. And unfortunately, when an individual, whether appropriate or not, has had access to medical management with the use of the opioid class of drugs, they become dependent at least. Some may even become addicted to it. And when they no longer have access, they resort to alternative methods of getting the medication they need. Sadly, with the amount of counterfeit medication on the streets today, people are turning to heroin, which is much cheaper, and much of that heroin has drugs like fentanyl and carfentanil in it, and these are extremely potent and lethal narcotics. And the net result is, in some cases, the first time you solve your problem by buying a counterfeit pill is the last time you ever buy a pill.
I think the medical community can be responsible for some of the prescription drug problem. One, because we still have lack of education. Education is key. If we say pain is the most common presentation to a doctor's office, we say the disease of addiction, let's say on the average is anywhere from 3 to 8% of the general population, excluding nicotine, which has dropped down to 17%. Why is an addiction and pain part of the core curriculum of the training of all physicians, all healthcare givers? So we do have a problem. We have an educational problem.
You know, I think just to add to that, one of the challenges, when we wrote the article, Universal Precautions in Pain Medicine, firstly we qualified it to say this isn't the end, this isn't the definitive work, this is a beginning of a dialogue. And it was a dialogue that dared to say that if you had a pulse, you had a risk. And that risk is part of the human condition. And so each of us as clinicians needs to be able to assess to some degree or another, whether that's a low risk, medium risk, or even high risk. And more importantly, from the clinician and the patient's perspective, how to manage that risk. So some doctors are trying to, and researchers are trying to take the position that if we simply focus the modality, opioid therapy, on the low-risk patients, the no-risk patients as it were, we could deal with the use of opioids in society more safely and more effectively. The problem is there's always risk. And so what we haven't done, and I think Howard would agree with me, is we've taught people how to start opioids. We've taught very few people how to assess efficacy and the concept of a trial of opioid therapy. And most importantly, we've taught very, very few people how to exit from the opioid class of drug.
Well, and I add to the exit, the main way that doctors exit now is fire the patient, which is wrong, because then the patient's out there by him or herself trying to find a solution. So as Doug said, fire the molecule, but don't fire the patient. Work with the patient. The majority of patients that we see are good people with bad problems, and they just need somebody who understands, who believes them, and will help them with all behavior problems or whatever problems they have, both of physical pain or behavior problems. I think it's very important that you take an inventory of your skill level, your educational level, your comfort level in treating a chronic pain patient, especially if Schedule II or Schedule III medications are needed. So the first person you have to examine is yourself. Are you comfortable with that person? Are you comfortable prescribing to that person? Do you know federal regulations of prescribing a controlled substance? Do you know how to follow up with that patient? Do you know how to treat that patient or at least refer that patient if the pain syndrome and the medicine gets out of your comfort level? So the problem is that you have to do what you're comfortable doing, and that is, you have to do a self-exam, and the first person you examine is yourself.
But Howard, isn't there a risk that in a very simplistic sense, I can simply say I'm not comfortable, and so I don't do opioids?
Well, that's the easy way out. Okay, if you don't do opioids, if you don't do insulin, then you have to have somebody that you could refer that patient to, whether it be a diabetic or a chronic pain patient. I think it's a cop-out to say that I don't do it, That's saying to me that I'll only take the easy patients, I will not take the challenging patients. And to me, that would be a very boring practice, but that's me.
And education is going to be key, but I think there's also got to be a rejigging of society's approach to the molecule, to the nature of what opioids are. Somehow, for some reason, opioids became the gold standard in all types of pain. And really, as an anesthesiologist, the only place opioids are the gold standard is in the OR, in the short and very finite role of managing the acute pain of surgical interventions. When you start using them chronically, they initially work for many people, but they don't work sustainably. And I think we have to rejig the magical thinking around this class of drugs. The reality is, patients don't generally come off of opioids easily, regardless of whether they need them or not. You have to have a strategy for getting off of the opioid class of drugs, and that strategy can't simply be an indeterminate length of taper, because that isn't ideal. Sometimes, again, contrary to popular belief, practitioners think if you go slowly enough, there'll never be withdrawal in all people, and that's just not true. You can mitigate withdrawal, you can minimize withdrawal, and you can certainly do it very badly and almost ensure that there will be withdrawal. But in some people, you simply have to push on and educate the patient, reassure the patient, and where in some cases even co-manage with other medications to blunt the withdrawal. But you have to remember the goal is to drain the swamp and move on.
Well, you have to also understand that chronic pain person or patient is a very lonely person. And it's a lonely place to be if your colleagues don't believe you, don't want to treat you accordingly, give you the respect you deserve, just like the same respect as you have hypertension, diabetes, like any other medical problem. Very lonely place to be.
And so it is a challenge. And at the same time, we need knowledgeable clinicians who are willing to step back and say, you tried that before and it didn't work. And when it didn't work before, we said we'd try it one more time, and here we are now being asked to try it a third time. We gave it the best try we could. We've got to move on to something different.
I always had options to give to the patient, whether it be opioid options, whether it be non-opioid options, whether it be physical therapy, whether it be counseling, whether it be psychological testing, etc. In other words, pain involves every part of your life. It's a biopsychosocial problem. And therefore, I always have something I could give to the patient. I'll always work with the patient.
But for the majority of patients, especially when you can make a good faith argument that the reason you're acting the way you are is in the interest of safety. When the patient disagrees with you, you can invite them to go and seek an opinion of another clinician. More often than not, they'll come back. And when they do come back, it's not uncommon for them to say, well, can you talk to me about what you were proposing when I left last time? So that
work with the patient, communicate with the patient. The thing is, you always have, in my opinion, something you could do with the patient. And it all begins with increasing your communication with the patient, talking to the patient, because the patient will actually give you very accurate information if they know deep down that you care about them and you want what's in their best interest, and what's in their best interest may be in society's best interest, also in their family's best interest. Talk to your patient. And it's hard to do that now because they put like, you're supposed to do all this in 10 minutes or less. And it's difficult. It's very, very difficult.